Well, this is Bob Browner with the Part 3 series on improving Nebraska healthcare. Today I'll talk about what I'd like to see from a health plan based on my experiences. I spent 12 years as a chief medical officer of a physician network seeing data from the healthcare side. Now that I spend a little more time as a school board member looking at our own health plan, it has given me a little bit different perspective. So what I know is available and could be available but is not provided to most employers, this is what I think should be provided to most employers, especially if you have a large association plan or if you have thousands of people with uncovered lives that this would apply to. So last, on the first one, we talked about the lack of accountability and key performance indicators you'd expect in almost any other business. What we pay a lot of money for healthcare, and what we don't really get a lot from those in the middle about what we're actually getting. Are we actually making improvements when it comes to improving health and saving money? And for the most part, we are not. However, we could do this. In the past, I've used Medicare as the example, surprisingly, because Medicare has been doing this for more than 12 years. So this right here, this is a summary of Nebraska's accountable care organizations or large physician networks. They've been at this for more than 12 years. Here are the 7 in Nebraska. This data is all publicly available for Medicare on every health system that's an ACO contract in the United States. So these are the 7 Nebraska plans that many of you would recognize the names: Bryan Health Connect, CHI Health Partners, Nebraska Health Network, One Health Nebraska, places like that. So why aren't we getting this kind of information as an employer? Well, I want that information, but I'd want it a little differently. Medicare doesn't take care of pregnant women and children, so we need a little bit different quality metrics and some other things. So I'd propose a different list of quality measures than what Medicare is using it is. Some overlap, but a little bit different here. I'm not the only person proposing things like this, by the way. So if you look at CalPERS, which is the second largest purchaser of healthcare from a public entity in the country. This is California, that's the pension plan, but they also have health insurance for over 1 million covered people. They have a very similar list of quality measures. So if you look at their quality measure set, childhood immunizations, controlling blood pressure, diabetes, maternity care, depression screening, they're adding that to their plan for the exact same reason I'm advocating we do this for Nebraska. There's been a group of Nebraskans working on this for about 6 or 7 years now at the College of Public Health, trying to get Nebraska employers to use these same quality metrics because there's very good reasons why you'd use these quality metrics. So I'd create something similar to Medicare but with some modifications because commercial plan you'll be taking care of pregnant women and children as opposed to Medicare where you usually aren't. So I would take this, I'd break it in the same buckets. So on this, for buckets, you've got the cost and utilization near the top. You've got some customer satisfaction, the clinical qualities. I'd use the same buckets of care, but change it like this. And so I'll go through each section individually to say what things I would modify based on that Medicare example. So we'll start with the cost and utilization. So I'd add a couple things. I'd continue using the adjusted hospitalization and emergency room utilization because that's where you see most of your savings. But I'd break it down by age group. And for the adult age group, I'd break it down to both female and male. The reason is that the healthcare costs are quite different. In this 19 to 44-year-old age bracket, the women cost about twice as much as the men on a lot of plans. Basically, that's because they're the ones having the babies. Now, you could argue that, well, why is that cost being allocated only to them? The men are part of creating those babies too, and I think that's valid. But you just need to know from a comparison standpoint that it actually changes in the 45 to 64-year-old age group because the men start having more heart attacks and strokes, and women are for the most part done having babies. So the men became more expensive in the later age group. And so depending on the type of employer you are, you may have different ratios of male to female. So if you wanted comparability across industry, you need to see that. So, for example, why would you want those hospitalizations and ER utilization? If you look at the Nebraska results, that the groups with the lowest rates of both ER and emergency room and hospitalization rates, they're also the ones saving the most money. That's one reason you want that. They also have a different way of defining primary care. It's services per 1,000. I'd actually change it to primary care spend rate. Why do you measure primary care? Well, this article we pointed from last year looking at why the United States is so much more expensive than other countries. You note there down at the bottom that our primary care doctors are such a much smaller part of the workforce than the rest of the developed world that with higher performing health systems. And if you don't have good primary care, you spend more money in the hospitalization because you're not preventing diseases and controlling blood pressure well enough, for example. So I'd want to know that. What is our health plan doing, for example? I'd also then look at the experience of care. So there's a CAP survey that's been done in Medicare for decades now. I would want to know: are my employees getting timely care? Are they being treated well by their provider? Are they being sent to the specialists like you want them? Are the staff being helpful to them? Are they coordinating care? I'd want some of those metrics because, again, Going back to this Medicare, you'll see the two networks that have the best numbers here are also the ones that are keeping people out of the emergency room, hospitals, and saving the most money. So if you provide good, accessible care and take care of people's problems, they don't become issues that land them in the hospital or emergency room later. So I'd want to know that stuff. Plus, it's just inherently good that we know that our people are getting good care. Why aren't we asking patients what they think of the whole system? And in this case, in Medicare, they actually are, but we don't do that in commercial populations, which I think is a disservice to our employees. And then, of course, the quality of care. I would use those aligned quality measure sets in this as opposed to the Medicare, which doesn't measure mom and baby. So let's pick two quality measures specifically. Kind of like we've talked previously, high blood pressure is something you really want to cover because it's so common. In this NHANES report from last year, where they measured a random sample of the entire population in the United States, you'll see that the green bars, which is basically people over 40, more than half have high blood pressure. So a lot of people, leading to a lot of complications. The projections, so this is one of those little older one from June of 2010. Sure, improving vaccinations and mammograms and colonoscopies save lives, but nothing comes close to high blood pressure. Subsequent analysis kind of bearing some of the same thing. This study looking at the California marketplace and extending to the United States, that the blood pressure control could save 3 times as many people as colon cancer. They're both good actually, but if you're going to do one, you got to do high blood pressure. Also point out that Peter Lee here is actually a consultant for CalPERS, so again, they've been studying this and they picked their measures for very good reasons. So again, last year presentation, we talked about the cost of people older than 65. This is a different group, the ages of people 45 to 64, which is more in a commercial population. Again, high blood pressure, heart disease, diabetes. These are things you want to measure because they're the things that are really expensive. So going up, this is how fast the bucket's growing. Going to the right, this is how big that bucket is. These are big ticket items. You want to measure those and make them better. Going back to the pediatric and maternal, you'd want to measure prenatal and postpartum care because it's really important that women get prenatal care. That's what prevents infant mortality and complications. But it's also a cost issue. So if you look at the age 20 to 24-year-old age group, you'll see that pregnancy and postpartum care is the biggest bucket of healthcare. So why aren't we measuring that to make sure we're getting good stuff? And one reason we want to measure that we're getting good stuff is because if you look the age 0 to 19, this slide, ages 0 to 19, you'll see the most common, most costly part of pediatric care is the preterm birth complications. How would we prevent them? We'd prevent them with good prenatal care. So why aren't we measuring that? So I'd very much like our commercial plans start measuring that and make sure we're getting good care for everybody. It's also a problem in Nebraska, so this is a state map that Ted and I put together of adequacy of prenatal care across Nebraska. And there's a lot of counties that on average could use a little help there. They're not meeting the Healthy People 2030 goals. If we look specifically at Medicaid, most of our counties are not meeting Healthy People 2030 goals for adequacy of prenatal care. Again, that's important because on the back end, if you're not providing good prenatal care, you're going to get birth complications. So in Nebraska, if you look at the cost of what we're spending on neonatal intensive care units, it's almost $200 million a year. I'd much rather put that money someplace else if we could avoid some of these complications. And, well, we should be doing a better job getting our women in for adequate prenatal care. Other things I do is, in addition to these metrics and key performance measures, I think our health plan should start taking more of an active role in a couple buckets: price transparency, primary care payment, and some integration with employee wellness. And I'll give you some examples here. So for price transparency is kind of a tough one. So this is, if you want to, some things in price transparency have been oversold for 10, 20 years now. So the idea of high deductible health plans teaching people to be better consumers hasn't really panned out. And this Thomas Robertson goes through the evidence of why that's not really working out. There's a lot of things that sound nice in theory, but in reality don't work so well. One thing, for example, if you look at the percentage of the healthcare bucket that can actually be an incentive for people, it's actually a really small bucket, only about 11%. And even when they do have that incentive, which isn't there a lot of times, so for example, once you've blown through your deductible, it doesn't apply anymore. And so if you've got a heart attack, you don't really care about where you're going. You just want to make sure that you live. There's not an opportunity for consumerism there. But also, there's just not a lot because most patients don't have any access to the information to be good consumers. Kind of like last time, I talked about me being overbilled by some lab. I didn't know ahead of time, so how could I have been a good consumer? Because by the time I got the bill in the mail, it was too late. So really, I didn't have an opportunity to intervene and avoid spending an extra $1,000 on lab that I could have gotten for $1,000 less someplace else. So the ability for the individual employee to be a good consumer is very, very limited in our current system. However, as an employer, if we could see things like this as an employer, I have a lot more leverage to change things and just say, look, we're taking these people out of their network. They're charging us $1,000 extra for lab that really there's no justification for that. The employer could actually make a big difference, and CalPERS has done those things in California. The other things I do is looking at actively changing our payment system. So we talked about this article from Robert Pearl about the middleman mentality and how fee-for-service medicine is part of our problem, but nobody seems to want to go around that bucket. Well, we could actually start making some changes. So we could start measuring some overall buckets. So, for example, we can measure primary care spend rate. How much money are we putting in primary care to make sure that actually this is changing, trying to change some of the issues that we have. There's actually a lot of studying being done about this. This article in the Annals of Family Medicine, it's funny, basically this asked people what do they think primary care does and how much are we spending on it. So they asked what percentage of primary care needs are addressed, what percentage of healthcare needs are addressed by primary care. Most people think it's about 55 to 60%. Actual is about 50%. And they asked people how much money is spent on primary care as the total of everything. People thought half of the money was going to primary care, when in reality it's about 5%, nowhere close to where it needs to be. So the summary for a lot of these folks working on primary care spend is our healthcare budget's way out of balance. Primary care doctors and nurses provide half of outpatient care, but they only get 5 cents of every dollar, so no wonder they're struggling to provide you good service. And high-performing systems spend 10 to 15 cents, so why don't we actually make a difference in this? Across the country, states are making a difference. So this primary care collaborative report actually does track state-by-state interventions. Here's a couple examples from states near us: Arkansas, Colorado, and Oklahoma. I've highlighted that Oklahoma in its Medicaid system has actually mandated now that at least 11% of the Medicaid funding go to primary care to try to address this issue. So this is just a couple states away where the state has actually taken an active control of this. I'd also like to have us experiment with direct primary care. So there are groups of doctors out there right now who will contract with you directly and basically bill like your cell phone bill. Say $7,500 a month. Here's your primary care. There's no middleman. There's no percentage being taken by these middlemen in between. Why don't we try to experiment this out with our health plan and see if this actually makes a difference? Because we could cut out a lot of administrative costs, get exactly what we want for primary care, for example. So why don't we do some pilots like that? Another example is tying our employee wellness to what we're trying to do. So a while back, I used to work with WorkWell, which offered an employee wellness program to employers. And I really liked how the reports were done because it really broke into the buckets that evidence that would say, if you do these things, you will be healthier. When you went through the program, they did all the right things. They did the surveys you needed. They actually measured the lab that was recommended. They actually measured people's blood pressure, and they used waist circumference, which is a better measure than BMI or height and weight. And then at the end, you got this report back that actually, A, summarized how you're doing, but B, it was something you could take to your physician, and this is all the same things your physician is already looking for. They're already wanting to draw this screening lab. They're wanting to measure your blood pressure. The good ones are focusing on depression, anxiety screening, for example. If you walked in with this, it would save a lot of time and get you right to the discussions you need, and hopefully get some of these conditions better controlled. So I would love to have an employee wellness program that integrated with our wellness, with our health plan, and then I could see on the back end, is it actually working? Are people's blood pressure getting controlled, and is it resulting in reductions in hospitalizations in the emergency room? If I had something like this, which is something I am trying to work on in my school board role, I think this would be much more effective. And tying it all together, there's a lot of win-win here. So, I mean, if you had better employee wellness, you'd have less absenteeism, better productivity, or healthier, happier employees, which is good in and of itself. If you had better access to primary care, you'd have better control of health problems, better experiences of care, which is inherently good as well. And at the end of the day, you'd have healthier populations and lower healthcare costs, all of which would be good. So it would be great if we could get a lot of employers working together on this. Which is going to lead us to part 4. So next time in a few weeks, I'm going to put together the final section of this and looking at some state-level solutions, because not a lot's happening on the federal level these days, but the state level, they're working on healthcare cost targets, primary care spend rates, and business groups on health. And so I will talk about that next time. And again, if you want to do more reading, I've put the links here so you can, in the notes section, so you can go to the YouTube video, click on the notes section, and pull up each of these articles and read them yourselves if you want to. So hopefully that's helpful to you.